Hello and welcome. This training module focuses on the value of assessing and monitoring psychosocial health in pregnancies complicated by diabetes. I am Harsimran Singh, a health psychologist and a research scientist at the Mary and Dick Allen Diabetes Center, Hoag Hospital in Newport Beach, California. And I'll be co-hosting this webinar with my colleague, Anna Pimentel.
Welcome, everyone. My name is Anna Pimentel, and I'm a licensed clinical social worker at the Allen Diabetes Center. I work closely with all our patients who come in with diabetes to address their psychosocial needs. So I get to see, all our women with gestational diabetes or women with type 1 or type 2 who are currently pregnant or planning pregnancy. So I look forward to discussing different tools that I use later in this presentation.
Thank you, Anna. So here is our standard disclaimer. Anna and I do not have any conflicts of interest to disclose. Now, here are the objectives for our presentation today. Now, the topic of psychosocial health in diabetes and pregnancy is really very broad. But for purposes of this talk, we felt it might help us to focus on why we should value psychosocial outcomes. Why is it even important to talk about them when we have such a significant clinical caseload? When should we assess them? What to specifically focus on and at what stage in pregnancy? And finally, how to finally do it. So these are our objectives. We will be reviewing changing trends in pregnancy, their impact on clinical and psychosocial care for women, discuss the importance of a multidisciplinary approach in the management of pregnancy with diabetes, then specifically examine the importance of culture and cultural considerations as when we are caring for women who have the problem of diabetes during pregnancy. Then determine psychosocial and behavioral components of diabetes management. And then finally, describe effective tools to improve patient engagement and other outcomes in pregnancy with diabetes. Now, before we delve into psychosocial concerns and problems we can anticipate while managing diabetes in pregnancy, it's really important to understand how our pregnancy-related demographics have changed, in the last few decades, and how that can impact the psychosocial health of our patients. So, based on recent statistics from the CDC, we are finding that women in the ages of 30 to 34 years have a significantly higher birth rate compared to our 25 to 29-year-olds. And this is across all ethnic groups in the US. So, an average age of first birth in 2017 was about 28 years and, versus 21 years in 1970s. So that might not seem as much, but if we just look at the kind of patient population that's coming into, clinics nowadays, about 30, pregnant for the first time, the kind of context, life context that they bring to the table, the stressors that might be added, once they're older in age, the patient brings all of that to the consultation. They may not necessarily talk about that, but it helps to be aware that the patient population today is very different from what it looked like 30 years ago. So, these changing trends are a result of a variety of things. We have a reliable birth control system now. There's a, education attainment has increased significantly in our women. There's a level of professional achievement that has come around, and there is this need for financial stability that has resulted in this later birth rate, amongst other reasons. Now, the impact of this shift of delayed pregnancies has its pros and cons, which we can identify under clinical and psychosocial categories. Now, women might be planning to have kids later in life because it allows them an opportunity to have more control over their professional and personal lives, achieve certain milestones, including financial responsibility. On the other hand, however, it does come with an advanced maternal age. It's a higher risk pregnancy, and the risk of complications attached are much greater. There is a decline in fertility and just general life stressors, as I mentioned earlier. Now, all of these factors have a considerable psychosocial impact, which, if left unmanaged, can be quite detrimental to patients' well-being. Now, I feel diabetes management during pregnancy, brings about this wonderful, unique opportunity, which allows us to tell the patient, that there is a multidisciplinary team at work to give them or help them achieve the best optimal outcomes. And in many ways, I do feel that pregnancy, although a clinical condition, has a very strong social and personal context to it. Just about how, pregnancy is managed, and the majority of the pregnancy for those 9 months, including preconception, after pregnancy, is managed outside of your clinic. So it kind of necessitates management by a multidisciplinary team and beyond, our traditional medical model of a physician, an OBGYN, maybe a nurse involved. There is a lot of other, there are other specific needs that the patient has today that might not be met in that traditional model. So a typical team who's caring for a high-risk pregnancy today might include, definitely our physicians, our wonderful nurses, our educators, dietitians, but we also see this increase in involving behavioral scientists. That includes our psychologists, our social workers, outreach workers, helping patients get connected with resources, as well as some specific needs that our patients might have, like pharmacists, that we constantly get questions about: how does this medication impact my growing baby? Would I need to take it throughout my pregnancy, and stuff like that. So just because of this shift, demographic shift in pregnancy, the kind of questions and the needs of the patients have changed as well. So it is important, that various team members coordinate their efforts to present a very joint support front to the patient. And we often find in our center here, our pregnant or to-be pregnant moms complaining that they do not feel that their team members, care team members, share notes, about how best to manage them. And the patients end up feeling very frustrated because they feel at every consultation, if they meet somebody else, they're going to have to discuss their entire history again. They have to discuss their problems again. And that can get a lot. It can get too much for a mom who's handling a lot. She's exhausted. She's frustrated with her condition. So there's a lot to be said about having a very coordinated support network in terms of the clinical teams that is available for moms for our best outcomes. In terms of our patient-centered functions, I do want to highlight that it helps to concentrate on these 4. So we want to kind of support the patient in their self-care. I mean, that is the #1 thing that we do in terms of chronic conditions, right? Most of the self-care or most of the burden of the disease is on the patient, and we understand that most of it is self-management, specifically in diabetes. That happens outside of the clinic. So we are there to support that patient understand that and have a sustainable attempt at managing diabetes. We help them develop short-term and long-term goals, and that's not enough. Just coming up with a goal as part of a consultation and letting the patient go, we know doesn't necessarily result in behavior that's acceptable. So what we do want is we want to kind of work with the patient and come up with a plan on how to achieve that goal, and that needs to be part of that consultation as well. And then finally, and very importantly, we need to screen for diabetes complications, specifically during pregnancy. Now, my team members and we often revert back to this, wonderful holistic quote regarding, our expectations of outcomes in pregnancy as as clinical providers. And, traditionally, we've often thought of pregnancy or any help we can give our moms during pregnancy as, our aim is a healthy mother, healthy baby, and that perfectly, is perfect, absolutely stays. However, again, as I mentioned, because of this shift in our demographic setup and the patient population, I think it almost necessitates that we move a step further here. And we want to talk about a happy mom. We want to talk about a happy baby, non-traumatized, empowered, and elated. And I know some people might get slightly uncomfortable with the word, happy, and it is subjective, but all the more reason that we try and focus our efforts on not just clinical outcomes, not just on objective measures. When it is pregnancy, it is extremely personal, and it helps us to move a step further and talk about happiness, whether our moms are happy, do they feel empowered? If they want to become pregnant again, do they feel they have that confidence that they will be able to go through that journey again without leaving them traumatized? Now, achieving this target of a happy and an empowered patient is impossible without acknowledging and working with the patient's way of life, their beliefs and support networks. So we might be able to struggle through and just about get some clinical success without considering psychosocial aspects. But really, I mean, I think, given our clinical practices and what we learn from our patients every day, we know without understanding and focusing on psychosocial health, we are not able to sustain clinical success. How does the patient feel about what we are telling them, and what are we asking them to do? And questions like these do impact clinical success related goals and patient engagement. Now, while we are discussing the importance of letting the patient drive their care plan for optimal success, I think it's a good time to highlight the value of cultural competence, specifically in our providers. Now, I think, it's so common to hear cultural sensitivity, cultural competence in healthcare nowadays. And I think some of the definitions, in my view, are just extremely complicated and necessarily don't need to be, because if you think about it, at the very basic level, culture is a way of life. And yes, it might reflect a certain group of people who are indulging in similar things. They might have, similar moral, religious beliefs, but really at the very fundamental level, culture is a way of life. And I think if we look at it that way, it becomes much easier for us to connect with the patient and bond with the patient, because, just like they have a way of life, there are, preferences that we enjoy, or things like we would like to do if we were a patient. And the other thing is, it's important to understand that culture is pretty multidimensional, and it includes a lot more than what most people think. Because if you talk about culture to general, patient population or providers, we often hear people say, oh, it's their religious belief. That's how they do things. But culture is way beyond that, because it includes your communication patterns, it includes your decision-making styles, what sort of support you seek, when you seek it, your family relationships, and treatment preferences. So you may choose to ignore the fact that, that a person brings a certain level of culture to a clinical consultation, but rest assured that culture is impacting their understanding of what you're telling them. It is impacting on how they might engage themselves in self-care. So this brings me to the final point on this slide. And, I bring this up because I often, when I give talks and, the kind of questions I get from people, it makes me think that quite often than not, people think that culture is something that needs to be associated with a certain ethnic group. So, oh, I'm talking to an Asian patient, I should be culturally sensitive. I'm talking to a Hispanic mom, and I should be culturally sensitive. And I think sometimes that's kind of a disservice I think we do to ourselves as providers, because every individual who walks into your clinic has a culture, whether they are Caucasian, whether they are African American, whether they are Hispanic or Asian. So it is important to understand that culture is not just referring to patients from a certain ethnic group. So based on the definition that I've just shared, any individual should be treated with cultural sensitivity. So someone who is, let's say, coming from Silicon Valley here in California will bring with them a potentially different culture versus a woman who walks in, from West Virginia. So they may both be Caucasian, but the kind of expectations they have of that consultation will be very different. And that's their culture, and that's their way of life. So no matter which ethnic group they belong to. So similarly, as providers, if we just look at, and I always share this with our team here, that if we just look at our team, just at our team here in the Diabetes Center, it's an extremely multi-ethnic team. But it's amazing to see similarities across cultures. When we do things or how we talk to patients might be very similar, but in other parts we are just totally different. So keeping that in mind, that it's not just the patients who bring the culture to the consultation, you yourself as a provider are adding to that consultation with your cultural background. Now, in terms of patient-centered care, again, just like culture, I feel like patient-centered care is a term that has been overused, in my opinion, without people fully understanding the potential and what it means, to have patient-centered care. So I really like this definition, which, comes from the Institute of Medicine on how they define patient-centered care. So if you think about it, they refer to it as providing care that is respectful of and responsive to individual patient preferences, needs, and values, and ensuring that patient values guide all clinical decisions. Now, to me, in this specific definition, I think three terms stand out the most. One is respectful. We have to be respectful of what the patient brings to the table and try and avoid being judgmental, whether, they are running an HbA1c of 13% and want to become pregnant. Because us bringing in a judgment to that table does not help that patient at all. So being respectful of what has happened in the past that led the patient to end up there in that situation. Being responsive to the individual's needs. That means coming up with a care plan that is effective for that particular patient. And then keeping the patient front and center in terms of all clinical decisions. So let the patient values guide the care plan. Moving on, I really wanted to share a few case stories with you that highlight the need to understand our patients and their clinical conditions in context of their lives, situations, and experiences. So again, these are all individuals. Anna has helped here as part of our diabetes center management, and she and I often discuss this. So I think bringing this to the table might add value to what we are discussing today in the presentation. So for this particular individual, she was a 35-year-old Asian Indian woman on her second pregnancy and had been diagnosed with GDM, already had a child, I think 4 years old, and no GDM in previous pregnancy. Now, if you just look at the routine presentation in this individual as a patient, and think about a plan, a care plan that you might have. If she's coming to your clinic for education for GDM, what might you consider giving or adding to her care plan? Now, look at the psychosocial presentation for this specific individual. So after the individual met our social worker, these were the things that were highlighted as part of that consultation, which we may have quite easily missed in the clinical context. So we found out that she really wanted to avoid animal protein, not just because of religious reasons, but also specifically they made her very nauseous. But she didn't want to bring it up to the dietitian because she felt this made her stand out and that the dietitian might not respect the fact that she's coming from a different background who doesn't appreciate eating meat before she goes to bed. She works full time and she was exhausted. She has a toddler at home. She prepares her meals for the rest of the family, and she really wanted to come up with a meal plan that she didn't have to work, separately outside of what she was feeding her family. She did not have time to go out for the walk. She didn't really want to go out in the evenings alone for a walk, so that didn't work for her, although it was recommended to her as part of the clinical plan. And she was unsure, this was very interesting. She was very unsure why she was diagnosed during the second pregnancy when she had a perfectly healthy pregnancy the first time around. So clearly there was a disconnect in terms of how the diagnosis was released to her, how was she explained what GDM is, because she still came to us with lots of questions and very unsure if it was even true she had GDM. And her primary concern really was not to use any medication to manage her blood glucose levels. Now, if you look at the difference between a clinical presentation and a psychosocial presentation, I can assure you your care plan is going to be very different for this specific patient. So here we have our second case again, and please keep in mind the ethnic backgrounds that we are sharing for purposely. We chose patients from different groups just to let you know that, culture sometimes is not the reason why patients bring different contexts to the clinic. So this individual, she was a 37-year-old African-American woman, had type 2 diabetes, had had a successful pregnancy before, and but since then she's had 2 miscarriages. And she was culturally, currently she was 8 weeks pregnant, on medication, checking her blood glucose twice a day, but the average readings were pretty high for somebody with a pregnancy. So looking at that, I can assure you, the first thing that comes to mind is, oh, she's non-adherent. She's the horror that we might feel as providers about, oh my gosh, she's 8 weeks pregnant, her sugars are really high, and you have this urge to jump in and tell her what she should do, and what she should not do. Now, stepping back for a second, again, after her consultation with our behavioral social worker, we realized that there were some things that in the background we needed to know before we jump in with our care plan with her. So she was not very motivated in terms of this pregnancy because she was definitely convinced that she was going to lose this baby. Because of her past history with miscarriages, she did not think that it was even worth her effort to try and manage her blood sugars anymore, because of course it was going to end up in a miscarriage like it had in the previous 2 times. She had had very inconsistent diabetes education, but she didn't know that it had been inconsistent. So there was a difference, because once we started talking to her, she realized there was a lot of information she had never heard of, and she had received most of the education as part of her church group. She did not understand how her diabetes medication was helping her blood glucose levels, so she was not taking them as was prescribed, and definitely wasn't monitoring her blood glucose because she said every time I look at it, it's always high. In terms of support at home, her husband was a truck driver, so most of the times was away, so she was all alone with her 6-year-old son. So again, if you look at this presentation, very different from what it might have been clinically, and we know when we look at the psychosocial presentation here that just talking to her in terms of what she should do, take your medication on time, make sure you are checking your blood glucose 4 times or 5 times a day. It's not going to, it's going to fall on deaf ears because somehow there is a background to this that needs to be addressed. In terms of our third patient, this was a 29-year-old Caucasian woman with pre-existing type 1 diabetes, and she was planning her pregnancy and trying to get her blood glucose within the recommended range, but she was currently at 7.4%. She was using an insulin pump, not a CGM, and she was monitoring her blood glucose about a couple of times a day. So you look at that. She has an insulin pump. She's doing pretty well in terms of monitoring her blood glucose levels, but we are not likely to recommend that she become pregnant with an HbA1c of 7.4. So again, if you just look at that, our care plan or recommendations might be quite different. However, if you focus on the psychosocial presentation for this individual, we realized that she had been extremely anxious about the complications during pregnancy and childbirth, but really wanted to be a mom. She definitely wanted to do that, but she had heard so much about what could go wrong, she wasn't sure how best to proceed. She was not getting a lot of support at home because her spouse didn't want her to go through this journey and be hard on herself, so he wasn't very keen on this pregnancy. She mentioned to us that she had changed the providers quite a few times because they had used scary tactics to motivate her to improve her blood glucose levels, which just made her all the more anxious. So at this point in time, when she came to meet Anna, she was just extremely demotivated. She was very exhausted with her efforts and wasn't sure how best to turn this around. And again, now having looked at the psychosocial presentation, we appreciated why she was struggling with 7.4% HbA1c. Now, we often look at pregnancy overall, whenever we talk about the importance of managing psychosocial outcomes in this condition. So just looking back at the, case stories I have mentioned to you, or whenever we talk about how can we help our pregnant moms, I feel we always look at this, we always look at the problem of pregnancy as just being one phase, that this is one stage in an individual's life. Let's help her through it so that she can come out of it as best as is possible. Now, that is great. However, I think if we look at pregnancy as just being one stage, we somehow miss the specific needs our patients might have before pregnancy, during pregnancy, and after pregnancy. And these needs could be very different from just looking at pregnancy as a whole. So we do recommend that it's important to divide pregnancy-related psychosocial care into different phases and then try and tackle each phase because the patient needs and values are very different. So let's suppose, we go to our first stage. Our first stage is preconception. And I think we often are less likely to talk about preconception and the importance of intervening during preconception. So what are the clinical factors that we might focus on, if somebody is planning pregnancy? We want to look at their pregnancy-related history, if they've had any difficult time before then, they've tried for pregnancy before, what's the overall health, their self-care practices, and any specific history of substance abuse, etc. But in terms of psychosocial factors, we have a variety of things. So specifically, we want to look at the stressors. What is the life context at this point in time? Do we want to screen for any depression, anxiety, distress that might complicate things as she's moving towards pregnancy so that we can tackle them earlier? Any history of mental health concerns that we need to be aware of? And then quite often, while we are focusing on psychosocial, we forget that support networks and social factors form a very important part of this psychosocial screening. And that's reviewing their support network. So if we find that the individual is pretty lonesome, doesn't have a strong support system, that's something we can encourage at that time because we know she's going to need that at the time of pregnancy, and then it might be too late for her to form new networks or come up with any support groups she might want to join, etc. In terms of interventions and outcomes at stage 1, I think we can primarily focus on looking at the patient and supporting them through their clinical goals. So if it's a woman who is helping or is aiming to become pregnant, we want to look at her clinical goals. Where is she at right now? And how long is it going to be before she can, realistically consider trying for pregnancy, and then putting it in a way that is very self-supportive, but at the same time making her feel that we are there as a team through the ups and downs as she tries to become pregnant, rather than making the patient feel that it's a test. If she's not able to get her HbA1c down, it may never happen. And we realize even past research has shown that doesn't help the patient at all, because they do go ahead and do what they wanted to do in the first place anyway. And then the other thing we want to do is make sure that we are connecting the patient to resources that can help her prepare effectively for the pregnancy. Now we come to the second stage, which is an extremely important stage, probably more important than the other two, is once the patient has become pregnant. Now, during this, we, of course, clinically, we do look at their pregnancy-related risks, any specific complications that might be, concerning the patient. So we often find our type 1 moms being very concerned about hypoglycemia during pregnancy, and we find that they've started changing behaviors that are actually not helping them. So they do tend to keep their sugars high because they're just too scared of going hypoglycemic. So that's something to talk about because it's impacting their BGs. Other factors in terms of our psychological factors, we do want to focus on any support at home. How is that going for the patient? If they're satisfied, they're comforted, any level of stress, guilt, depression, any past trauma that might have come up now that the woman is pregnant. What is the motivation for self-management? Because even under best circumstances, a pregnant mom can get exhausted, and so how is she keeping up, and how can we best support her during that time? Any specific phobias that come up, and I'll share an example, a case story later on about how pain management ended up kind of overtaking the entire experience of GDM management just because of her past delivery. In terms of our interventions and outcomes for during pregnancy, again, I think our focus stays on making sure they are meeting the clinical goals, but ensuring that they have the support network to do so. So we do not want to let the patient feel that they are all alone in their journey to meet a certain specific clinical goal. We achieve much better outcomes if the patient feels we are all in this together and that they can count on us in case there's any help needed. Finally, we have after pregnancy. In terms of after pregnancy, just like preconception, we are less likely to talk about after pregnancy, specifically for women who've had a successful pregnancy, because we feel, the patient is exhausted, they've had a successful pregnancy, they can take some time off, they can put their health on the back burner because now they are, now they have to care for the baby. And that's understandable. And of course, we want to do that. However, we want to be aware not to lose the momentum that the patient has gained during pregnancy, especially if they've had a successful pregnancy, because now they're motivated, they have achieved the target. So we need to strike a right balance of giving them some time off, but at the same time keeping them motivated that they need to come back and get in tune with their health again. And in this particular area, for psychological factors, we want to definitely screen for depression, distress, anxiety, which is very high in our postpartum moms. Any stress that was a result of the delivery outcome, specifically if it wasn't a successful pregnancy, what level of mother-baby bonding is going on, and if there is any level of improvement there, what's the confidence in motherhood? Because if she's not had a successful pregnancy, that might have impacted her a lot more. And that's where our social workers can come in to help the patient feel motivated about becoming pregnant again if she wants to. And a variety of social factors, again, can help in this regard, support networks, connecting the patient correctly to the support groups that might be available. But in cases of successful pregnancies, you also want to start looking at cultural differences in parenting practices, as well as any breastfeeding practices that are pretty different in different cultural groups. Again, in terms of our interventions and outcomes, again, the focus is on clinical outcomes, definitely, but at the same time, making them feel psychologically healthy and happier after they've had that journey. Before I hand off to Anna, I wanted to take a couple of slides and mention how we could start introducing psychosocial resources as part of a clinic, because we often get asked when we share our results with people, how do we start introducing psychosocial support? Because sometimes the patient is not ready, sometimes the clinicians are not ready, and how do we do that? So here are a few points that seem to have worked really well for us. So what we want to start off is making sure that the patient appreciates the difference between somebody who's working for clinical outcomes and the other person who's working towards their psychological health. And if we do that, the patient appreciates that this has to happen together, or that this has to go hand in hand, because sometimes they might get confused about, oh, why can't a nurse help me through this? Or why can't a social worker tell me why my BGs are high? And to some extent they can, but at the same time, it's important to keep things different so that they appreciate they have to work separately on both of those two aspects. Now that goes the same for our providers, because we often find there is a certain level of resistance in terms of providing or integrating psychosocial services as part of routine clinical care. And it definitely takes time, it definitely takes resources, but rest assured the results definitely are amazing, as well as specifically for the patients. So what we find is it helps to have a chat with your team so that they're all at to bring them on the same page in terms of what does a social worker do? What are the specific services or the resources that a social worker can bring to the team and to the patient? And the same goes for a psychologist. And I think sometimes there is confusion in terms of their roles and how can they help the patient. So if we can help our clinical team understand the significance of psychosocial health and how they can help the patient, and to be honest, take the load off the clinical providers in many ways, I think we have a much better success rate in working together as a team for the patient. Another important point that we have, Anna and I often talk about here at our center is we find that our patients understandably take longer to show improvements in psychosocial health compared to their clinical health. So we often find our team members thinking, oh, we are probably not helping the patient that much, or the patient is probably not getting much out of a psychosocial consultation. What we forget is any improvement in psychosocial health does not necessarily mean the patient comes to us and says, hey, I'm feeling great. What it might mean is they're actually testing 4 times a day instead of 2. So the clinical successes that you might find in your patients are reflection of the psychosocial improvements that they have made themselves. So sometimes that's important to bring it to the team and discuss what the behavioral scientists do as part of the team. And here is the last case that I want to share before I hand it on to Anna. And this was specifically in terms of pain management. So we had a 34-year-old Chinese woman on her second pregnancy, but first-time GDM diagnosis. She had great family support. She did not work at that point in time, and she was attending her first appointment for GDM management. Now, when you first saw this patient, she looked very calm. It seemed like everything was well together, and this would be this was probably a textbook case of everything going well. However, when the individual started talking with Anna, we found that she had had a horrific experience as part of her first pregnancy delivery, where her pain wasn't managed very well, and she had a very low threshold for pain, and that those experiences on her delivery really haunted her. So the patient came to us in extreme anxiety, much more than her anxiety about being diagnosed with gestational diabetes. So she was a higher socioeconomic status patient, doing really well. The husband was busy at work, but she felt like she could manage it as long as her pain, or we could kind of help her move past the pain management aspect of her delivery. So amongst other resources that she needed, I know that our social worker helped her understand and put a pain management plan in place so that she felt there was closure to that, and then she can work towards managing her gestational diabetes, because we did not think if we were unable to answer her problems there, we didn't think that person was going to focus on her gestational diabetes management. And this slide necessarily just goes through what I just mentioned to you about her pain management during delivery and just assisted her in developing a plan. Okay, so take it over, Anna. Thank you.
All right, thank you, Dr. Singh. so that was a great overview of just, kind of starting off where are we at right now with in terms of managing diabetes in pregnant women, and just some different barriers that might come up for our patients. And so now a lot of the questions are, well, how do we get there, right? How do we understand the psychosocial factors that come up for our patients? What are some tools or some skills that I can take back, during my patient care? So as a social worker, that's really my role, but there's, so many different tools and skills that, I'll be sharing in the next few slides that hopefully can help all providers, nurses, dietitians, physicians, to really build that motivation with our patients, build their confidence, and also help us better understand how to better address the different barriers or different psychosocial needs that come up for our patients. So the first tool I'll go over, very popular, motivational interviewing. It's a great, great tool. It's no wonder it's so well known, and really there's so many different trainings on motivational interviewing. I can go on for days about the different skills that come with MI. But at the end of the day, it's a really patient-centered, non-judgmental clinical technique that promotes behavioral change and elicits self-efficacy and motivation with our patients. A lot of the times we hear, about the word ambivalence, and ambivalence sometimes can be very misunderstood. A lot of the times we can see it as a patient didn't show up for an appointment, a patient isn't checking her blood sugar, they're not taking medication. But instead of seeing it as non-compliance or just being resistant to the care plan, what it really is ambivalence. And ambivalence means that our patient might just not be very aware of the situation, they might not have the tools, or they might just not know where to start. So MI really helps us explore those feelings of ambivalence, helps us, really build that collaboration in our treatment with patients. And at the end of the day, we're solely helping patients move out of ambivalence by giving them the tools and different support so that they have that confidence to slowly work towards those behavioral changes. So I'll go over just a few skills that come with MI. There's definitely a few more, but I wanted to just address a few and how we can, incorporate those during our patient care. So the first one, affirmations. This is a huge, huge tool to use. Many times, even just as basic human behavior, it's so easy for us to focus on negative, what I didn't do right, what's going wrong, what I still need to work on. But even the quick reframing of those situations, and even, in the beginning of the appointment, focusing on what is going right, even if to us it may seem like a small little step, those affirmations really builds the patient's confidence. And at the end of the day, the more self-efficacy and confidence that patients have, the better they feel, moving towards those behavioral changes. So I wanted to point one out that I listed there. And I think that's just such a powerful thing to say. Thank you for being here today. Whether it comes from a physician, a nurse, dietitian, whoever is meeting with the patient, that alone is really saying, hey, I know that for, just getting to the appointment today might have, required a lot of work. Maybe there's a lot of stress, a lot of anxiety or frustrations, but you're here today. So that's a great reframe for our patients to, start building that relationship and kind of normalizing that it is very difficult, and that they're in a difficult spot. So kind of reframing that to the positive that they did do that day. Another great one is reflective listening. Seems like a no-brainer that we would, be listening to our patients, but Dr. Singh actually, shared a study with me the other day, and it was talking about how they were looking at how long a patient talks for until they're interrupted by the physician during their appointments. And, I was thinking, okay, maybe a couple minutes. It's actually 11 seconds. So, I know we're all very short on time. That's just, how our healthcare system is nowadays. We're kind of in and out with patients, but that listening component is huge. And we can miss so many things by really skipping over that. A lot of the cases that Dr. Singh mentioned, so much could be just, just pulled under the rug if we don't really take the time to listen and explore those different barriers with our patients. So reflective listening allows providers to rephrase, you know, calmly listen to the patient and reframe back what they're hearing. Not only does that let the patient know, wow, okay, my provider is actually, you know, paying attention to the concerns that I'm bringing up, but it also helps the providers clarify any discrepancies that might be happening. Sometimes we think we're listening to something and the patient says, no, that's not what I meant, you know? So that's a great tool for us to really dig deep and be able to explore those moments with them. And kind of tied into reflective listening is listening for change talk. So this requires, you know, a lot of work. It really does. It requires us to really sit and be with the patient. Change talk is really paying attention to those statements that kind of shine that ambivalence. You know, sometimes we're with the patient, and if we're not really listening, it might sound like, oh, they just don't want to do this, or they're complaining about, you know, other things that are going on. But if we really start to pinpoint those points of ambivalence, we can start those conversations about, okay, there's definitely something there that we can work on, and how do we take those small steps? So the example we gave was, if I stick to my medication, then I would have better control over my diabetes. So it's not that I don't want to take my medication. The patient definitely knows the benefits that would come with it. But, you know, if we really didn't listen to that, or we kind of just, you know, ignored that statement that came up, we could have missed the chance of talking about, okay, so there's definitely benefits to medication. What are some barriers, and how do we, you know, jump across those together? And what are some ways that I can help you slowly, you know, build those into your care plan? Open-ended questions is another great tool that is part of motivational interviewing, and we'll kind of use this with one of the cases that Dr. Singh mentioned earlier. These are the questions that actually evoke change talk. Like I mentioned earlier, sometimes we're in and out with patients. It's just very quick. And so sometimes if we do the typical yes or no questions, there's so much that we can miss. Through open-ended questions, we're really building that strong patient-provider relationship, which, if you recall with the, you know, couple cases that Dr. Singh gave, that is huge. You know, if the patient doesn't feel that the provider has, you know, a little bit of time to at least explore my cultural values or my beliefs, my expectations with the pregnancy, a lot of things might not come up during the appointments. It fosters a really non-judgmental place, and the patient starts to feel encouraged to discuss their health care. And it also helps us not lump patients into, oh, you know, typical, maybe they're 30 years old, type 1. You know, every patient is so different. So it really helps us explore, where is this patient coming from? And this also refers back to how Dr. Singh mentioned, even things like culture, you know, exploring outside of that. It doesn't have to be specific to an ethnic group. You know, like she mentioned, someone from Northern California, someone from Texas, same ethnic group, could have very different beliefs or expectations with their pregnancy. So those are a few examples of different open-ended questions. I won't go over all of them, but I wanted to apply a few to case number 3, which was our young woman with type 1 who was, you know, planning on pregnancy, but was struggling with a high A1C. So a few questions that could come up with that patient. Even just something simple as, how can I support you right now? A lot of the times, you know, we're healthcare providers, we care for people, we're problem solvers. We want to jump ahead and start solving problems out of goodness of our hearts. You know, we want to help the patient, but there's so much we can miss. So even just taking a step back and, you know, that conversation, how can I support you right now? It might be something totally different than we were expecting. Another question with that specific patient, you know, she had type 1 for 19 years. If there's an expert on her diabetes, it's definitely her. So even taking a step back and what has worked for you in the past, you know, exploring that. I'm sure she's very knowledgeable, has a lot of different, you know, education on her diabetes, has tried so many different things. So kind of giving her the reins, you know, you're the expert, what has worked and what are some things that we can pull from that. Another question that we can go into is, what is something that we can start off, something feasible we can start off working with today? And that's a great question for any patient that comes in. We might think, okay, let's get started on the medication, checking blood sugar 4 times a day and following the meal plan. That might be, 10 steps ahead for a particular patient. We might have to take 10 steps back and start off with, let's just learn how to use a meter and take a few days to process in, then come back. So for this particular patient, maybe it's taking a break. Let's take a break. Maybe there's other resources she's looking for, other support that we can guide her with before we even start on the actual clinical component of her treatment plan. So stages of change model, another really well-known model, and it really emphasizes that change is not linear, and this applies to any type of behavioral change. If it was, it'd make definitely our jobs a lot easier, right? If patients could come in, be ready to take on, the different goals they have and achieve them and finish it up, but that's not always the case. And very similarly to motivational interviewing, it reframes these terms that definitely should be out of our vocabulary: resistance and non-compliance. We understand that patients are just at different stages of where they're ready to change, to make these different behavioral changes. We understand that some patients come in ready, very motivated, and others we need to start off with just maybe a little bit more education before we expect them to start implementing treatment plans. And a great important part of this is patients will move along or relapse depending on shifts in support, motivation, stressors, resources, and life changes. And that is very, very important, especially when we think of the importance of monitoring psychosocial factors that can easily change from one week to the next. A patient who's doing really well and is keeping up with everything, maybe work stress comes along, different responsibilities, all of that can quickly change how they're moving along through their treatment. So I'll quickly mention the different stages, and then we'll also apply it to one of the cases that Dr. Singh mentioned. Precontemplation is when we get patients, it might seem, it might look like a patient not showing up to an appointment, or you give them a meal plan, or they come back, they haven't checked their blood sugar. A lot of the times there's unawareness that a problem even exists. So they have a really hard time following up or identifying goals. And so we provided some, different questions that providers can use to kind of explore where is my patient at right now? And in pre-contemplation, it might just be, how do you feel about your diagnosis, or what do you know about your diagnosis? We know that sometimes, when they're provided their diagnosis, we assume that they know, or that we assume that they know things will be fine, that there's a treatment plan, that there's a reason why there's, a team of different providers, but that's not always the case. And sometimes even just, what does this pregnancy signify to you? In their life, in their certain, state, what does this all mean to them? And kind of start that conversation. In contemplation, the patient is aware that a problem exists, but there's no set plan or intent to change. So patients know that there's something that needs to happen. There's goals they need to work on, but a lot of the times they don't know with what tools. Things might just seem very overwhelming, so they just don't have that confidence to say, yes, these are things that I'll start working towards. In preparation, the patient is, has that confidence, is feeling more motivated to make those changes, and is building intent to take action. So I'm sure you'll recognize some patients like this where, like I mentioned earlier, sometimes it's just starting with, let's start just, talking about gestational diabetes. Let's start, working with the meter. And maybe right now we're not even going to start testing, right? Maybe we'll just kind of check in and slowly build up towards that. But in this stage, it's very important to know that small but realistic goals are what really work for patients. The more small goals they're able to achieve, the more it builds up that motivation and confidence. And then in action and maintenance, our patients are really actively modifying their behavior. That's when they're, keeping up with their treatment plan. Maybe they're doing really great at, monitoring their BGs, following their meal plan, keeping up with appointments. But even during these quote unquote perfect times with the patient, we should always be assessing. One, these are great moments to kind of pull in those affirmations, always praise the good, changes that the patients are making, and keep assessing, what is working for you, or are there any other support factors that we should pull in? How do we keep this going? Because it's very normal to reach that last stage, that relapse stage, where patients, like I mentioned earlier, due to different stressors, different life circumstances, can quickly fall off, and that change is interrupted. But relapses can be seen as a great learning experience, both for the patient and the provider. How do we prepare for this in the future? Or maybe we need to switch things around and have a different plan of action for you. And I wanted to kind of relate it back to a case that Dr. Singh mentioned, which was case number 2, with that woman who had one successful pregnancy and 2 miscarriages and just felt very demotivated. If we hadn't explored that a little bit more, we wouldn't have known that it was due to a lot of misinformation. She could easily have been in pre-contemplation because she just didn't know. She didn't have that appropriate education about, what is GDM? How is it treated? How do we, as a healthcare team, keep our women healthy to make sure that they have healthy pregnancies? So with that patient, working in the pre-contemplation stage, a lot of education, and even addressing other parts of her life to kind of build that confidence. Her husband was out a lot. So what other support systems can we pull in? Are there any, other barriers that are coming in to kind of help remove along these different stages? So the last tool I'll go over is a great tool to address cultural aspects with our patients. The learn model. It helps providers address cultural beliefs and customs and practices in our women coming in. And that can apply to so many different things, like Dr. Singh mentioned. Culture applies to, pregnancy expectations, customs that they have. We all have different expectations about food or even our health care. So the learn model really helps us explore all those different things. It helps us look at family dynamics, different customs, like I mentioned, and even their own personal goals with the pregnancy. And it's more of a collaborative effort, even if the patient's expectations are things that might be, wow, that shouldn't be part of their treatment plan, or how are we going to make that work? It's a collaboration. We know that if we go in and say, well, no, that can't happen, and you need to follow this, it's what's required, that's when we see patients, not really invested in it. So if we're able to build that collaborative approach, that relationship, we can incorporate, what we as clinicians, recommend to have a healthy pregnancy, but also taking into account what they want and need from this healthcare. So a few different tools with LEARN. So LEARN is an acronym. The first one is listen. Obviously, that's a very common skill around this, but listening with empathy and discussing her perception of the problem. So that is very important, especially for some patients that come in that don't really understand what gestational diabetes is. And even during our time here, we've seen, a lot of different patients, even just culturally, there's different stigmas around, having something like GDM during pregnancy and what that means about her health or things like that. But even just, like I said, taking a moment to listen. If you recall with one of the cases earlier, something like, my religious beliefs and things like that, animal protein is not for me. But if we don't take the time to listen, that might not have, like the patient mentioned, I felt like I wasn't, I would be maybe looked down upon, or maybe they would scold me for, not wanting to eat animal protein. So that listening component is huge. Explaining our perception of the problem. We can't always assume that a patient knows why we're doing the things we do, why we recommend certain things, and why a certain care plan is recommended. So offering support and comfort by informing the patient that it's a joint effort. So explaining, you know, on our end, this is why we do certain things, why certain medications are recommended, what GDM is, or, you know, how diabetes is managed during pregnancy. And then, you know, this is a team effort. And even as a social worker, it kind of goes back to how Dr. Singh explained, even explaining the multidisciplinary team. You know, why are there nurses and dietitians and my OB or my PCP, you know, all these different components, explaining that can be huge for the patient. Not only will it, you know, help them understand why certain things are happening, but also it'll help them feel supported as well. And acknowledging is huge. Acknowledging her thoughts, any worries that come up, you know, making sure that she is understanding the plan, or if there's any questions she still has, and taking the time to address, you know, if the woman mentions, well, I don't feel comfortable with a certain thing, or there's something else I want to add. And that's how we get to recommending different things, you know, recommending a care plan that is within her comfort, within her beliefs, within her understanding. And like we mentioned earlier, this can be even, how do we make this plan work with your work schedule? You know, that's a huge component of her life, or maybe other things that take priority, and knowing how to do something that's feasible with what she needs. And then at the end of the day, it's negotiation. And this is always ongoing, whether it's, you know, during preconception, during their pregnancy, and even post. Always revisiting their care plan, always making it a joint effort, and making modifications as clinical needs start to change or any psychosocial needs start to change. So I wanted to actually give a great example of this. Not too long ago, I had a patient. She was a 40-year-old Chinese woman, first pregnancy, and, you know, not showing up to appointments, wouldn't return our calls, didn't seem like she was testing much. So, you know, it could have been really easy to say, well, okay, she, you know, just doesn't want to, you know, follow through with the plan. The more I was able to explore, the more we came up with, she was unmarried, so that was already a very tough pregnancy for her. You know, a lot of stigma from family, they weren't very happy about it. So even just exploring what this pregnancy meant to her it made so much more sense to us as providers. Another thing was that she worked in a very high intensity, stressful job, just very demanding. And so she didn't feel comfortable telling her workplace that she was pregnant yet, which was why she didn't feel comfortable testing throughout the day. So if we would have missed that, I mean, that was huge. So for her to hear us say, okay, we're listening, we understand, let's recommend some different things. And it might not look like the perfect care plan. Maybe it might not look like her testing 4 times a day. It might be less, but it's something that, you know, is feasible for her, that she feels comfortable with. So as time went on and she eventually did tell her workplace she was pregnant, then we readjusted that. You know, we were able to support her and kind of help her, you know, figure out what times during the day she would be able to test and make sure she's eating throughout the day. And she thankfully had a great, you know, healthy pregnancy, but, you know, all these different components definitely come into play. So, you know, all these different skills are things that we can use to make sure we don't miss those moments. So the ADA, you know, really has different recommendations for psychosocial care. And most importantly, like what was mentioned in the beginning, psychosocial is not, you know, as needed. It should really be an integrated approach, a real collaboration in patient-centered care. And that's something that we practice here at the center is, even when I introduce myself to patients, this is an integrated part. It doesn't mean that it's only for stressed out moms or it's only for moms that have depression. Not at all. You know, that psychosocial health is important for every patient across the board. They do recommend we, you know, assess, once again, preconception, during pregnancy, post, for so many different variables: diabetes distress, depression, anxiety, even things like disordered eating, all of those are very important. The California Department of Mental Health actually just released a survey, and they were looking at, pregnant moms in California, and they released that 1 in 5 women actually have postpartum depression. So after pregnancy, 1 in 5, that is huge. So, this is very important to always be assessing. We're at a place where, with diabetes management, we get to see our moms very often, if it's every 2 weeks or even once a month. So always keeping that in the back of your mind, how are we assessing and making sure they're linked to the appropriate resources. Monitoring is key, like I mentioned earlier. Monitoring, making sure that self-management behaviors and psychosocial factors, are impacted. Different things can start to play into that. So always monitoring and assessing, what stage of change is my patient in? Are they, feeling confident? Are we losing, some of that? And how do I better support them? Assessing life circumstances, even before pregnancy, all of those come into play. And addressing psychosocial problems when identified, and always following up. If an intervention cannot be provided in the center, great resources outside of it, linking them to different programs or services, and following up and making sure that they were, appropriately connected. And even in future appointments, always making sure that they know that is a part of their treatment plan with us. All right, everyone. So thank you so much for participating today. Dr. Singh and I really enjoyed putting this together for all of you. So we hope we, got to touch a little bit on psychosocial health and the importance of it during, management of diabetes during pregnancy. And hopefully you took away some good skills and tools that you can use with your patients, back in your centers. Thank you, everyone.